Thank you for joining us today for the 6th webinar in the COVID-19 webinar series, Pregnancy, Delivery, and Newborn Care in the Era of COVID. I'd like to turn it over to Jermaine Lewis, who will introduce our presenters. If you have questions during the session, please submit them via chat and we will moderate those to our panelists. Thank you very much.
Okay. Thank you, Michelle, and welcome everyone who has an opportunity to join us today to talk about a very important topic, and that is pregnancy, delivery, and newborn care in the era of COVID. And as we all know, science is continually coming in to aid our understanding of COVID, so I'm looking forward to hearing the recent updates as to what we should do. So it's my great honor to welcome our speakers today, and I would like to start with our guest speaker, Dr. Katherine Campbell, who comes to us from Yale. She joined the Division of Maternal Fetal Medicine after completing fellowships in obstetrical ultrasound and maternal fetal medicine at Yale University School of Medicine. Her current research interests include maternal cardiac disease and reduction of maternal mortality and morbidity. And we're all painfully aware of the market disparities in those outcomes. She's also very interested in global healthcare, especially finding ways to strengthen healthcare systems to decrease the incidence of maternal and perinatal morbidity and mortality. Dr. Campbell completed her residency at Yale-New Haven Hospital and her medical training at Michigan State University, in the College of Medicine, Human Medicine. And as importantly, she has an earned MPH degree from Tulane University School of Public Health. So welcome, Dr. Campbell. Many of you may know Dr. Rosemary Higgins, who serves as the Associate Dean for Research in the College of Health and Human Services here at George Mason University. Rose comes to us from the NIH and previously other academic institutions. While at NIH, she served as a medical officer and the program scientist for the Eunice Kennedy Shriver National Institute of Child Health and Human Development's Neonatal Research Network. And this network is a large multi-site collaborative network comprising 15 clinical centers, or about 35 hospitals across the U.S., as supported by a data coordinating center. Much of our empirically based practice guidance in the care of infants and children in the neonatal units comes from the work of the network. So together we have experts who can talk about caring for mothers and pregnant women and all the way through caring for children born to mothers with COVID. So without further ado, I'd like to welcome our speakers to give their remarks. Thank you.
Great. Thank you, Dr. Lewis, for such a nice introduction. Really excited to be here today and share a little bit about COVID-19 in pregnancy and childbirth and give a little bit of a flavor of what we've been doing here in Connecticut to care for our patients, and then hopefully spend a good amount of time answering your specific questions. All right. So I'm our medical director of our labor and birth and maternal special care units. And today I wanted to talk a little bit about testing for SARS-CoV-2 at the time of childbirth, COVID-19 in our pregnant patients, and share a little bit about the creation of an OB COVID unit that we have here at Yale-New Haven Hospital. We are all brutally aware of the changing environment of the pandemic across our country. We in Connecticut were a couple weeks behind the peak in New York City, just sort of, as due to I-95 and the way the virus sort of marched up the interstate this spring. We really enjoyed, that a break from COVID this summer when the numbers really went down, and I think everyone felt that we were in a good spot until really recently, over the last few weeks, we started to see numbers go up. At first, in just one small region of Connecticut, this is around New London, and then most recently, this is the up-to-date data from the state. It's really just going across our state, and everywhere is seeing surges again, and especially here in New Haven. All right, so when COVID came out in Western Europe and on the East Coast and a little bit on the West Coast this spring, the world really stopped and paused and really changed direction with how things were done in healthcare. And you can see here our pause here, this is at Yale-New Haven Hospital, and you can see our census. So the white bars are normal inpatient census. And you can see with the peak of the COVID hospitalizations in the spring, highlighted by that blue line, we saw the concomitant decrease in hospitalizations for other conditions. And partly this was generated on purpose. All of our elective surgeries were stopped. As many elective hospitalizations were stopped in order to create enough space to care for the anticipated surge of our COVID-19 patients. But during this time, obstetrics does not stop. Childbirth continues, and there was really no pause. And so I think the challenge for our hospital and for our obstetrical team, our neonatal team caring for newborns, we had to simultaneously prepare for ongoing high volume of patients in the setting of a pandemic, and really had to figure out best practices in real time to keep our patients safe and to keep our healthcare workers safe during this surge. And through it all, our number one priority is patient safety. And we thought about all the different ways how and what types of things we can implement to keep our patients safe. And this was through screening. So our hospital set up similar to, I think, almost all hospitals across the country, very elaborate and thorough screening at all of our entries. Very significant changes in our visitation policy, which I'm happy to talk about more during our webinar today, because this has had a significant impact on our families. Staff screening recommendations, patient testing, and so we were one of the first OB units in the country to implement a universal SARS-CoV-2 testing algorithm for our patients admitted for childbirth. We developed an OB COVID unit. This is for our COVID positive patients. And then also a consolidation of our obstetrical services across our city. We had 2 separate labor and birth units that we consolidated in about 2 weeks' time to a single location. All right, so I'm just going to introduce our testing program. And not to get into the nitty gritty, but basically this is how we created our testing workflow. And this is for all patients coming in for their anticipated delivery hospitalization. As our hospital got our testing up and running, we were able to expand the recommendations for testing to include patients who were admitted still pregnant, but who were at higher risk for delivery. So for an example, this could be a patient who was coming in with threatened preterm labor, or a patient maybe who had vaginal bleeding and were at increased likelihood of needing an urgent delivery during their hospitalization. And so this algorithm was started at the beginning of April, which coincided with our surge, and it more or less has stayed very similar, with just small changes where we coordinate with laboratory, with infection prevention to make sure that all of our testing algorithms are working as smoothly and really efficiently as possible. And you'll see on this side this testing workflow. These are just highlighted bullet points for all of our providers and staff who are assisting with the testing program. And, this is, I think, too, an example of the devil is in the details. It sounds, putting together the testing program, but then what we really spent a lot of the time on are just these small questions that came up from time, on a regular basis to try to optimize and make sure our patients stayed safe and our staff and providers stayed safe during the testing. All right, so this is a result of our testing program, and so these are patients coming in for childbirth, and you can see the surge that occurred here in the middle to end of April. We lagged about 2 weeks behind the surge that happened in New York City, and then you can see over the early summer and into the early fall, we really just had a baseline low volume of patients who tested positive at the time of their admission. And the vast majority of these patients during this time were all asymptomatic. They weren't pre-symptomatic. We were able to follow them, and they weren't developing symptoms later. These were patients who really had maybe an old infection that still tested positive on their PCR test, or just had a subclinical infection that was not, recognized. And you can see most recently this uptick in cases. These numbers are up to date as of yesterday. And really interestingly, there was a study published by the CDC that they went to routine laboratories and they pulled extra serology, and they were able to look at seroprevalence rates in the ages of 19 to 49. And this was done across several states, including Connecticut. And I find it coincidental and very interesting that the seroprevalence rate for SARS-CoV-2 antibodies in this window from April 26th to May 3rd was around 6.1%, which more or less coincided with our peak PCR positive rate, which was just under 6% during that time, which gives us an idea that screening our population of patients coming in for childbirth really does reflect probably a pretty good, serves as a good proxy for cross-section of patients from Connecticut. Next slide. And then you can see too, just below, this is what's happening across the state of Connecticut. And again, a reflection of the surge we had in the spring and the next surge that we're starting to experience now. And you see it reflected in our patients coming in for childbirth. And so we published our experience with our universal testing program. And the numbers that I wanted to highlight here was just looking at some of our outcomes. So patients delivering less than 37 weeks in our positive patients were 0. And this compares to our baseline rate of about 8.5%, which is close to the national level of preterm birth. Cesarean deliveries were no different between our groups. APGAR scores, we didn't see a preponderance of low APGAR scores in our positive patients. And the birth weights were comparable to those who tested negative. And during this study window, we had no neonates test positive during their hospital stay right after childbirth. And then just a comparison here too. So in New York City, they published their data. This is from Columbia, looking at patients who were testing positive at the time of their delivery hospitalization. And it compares to our numbers here in Connecticut. And you can see a lower level of saturation of positive cases compared to New York City, but reflective in the ratios of patients who are symptomatic versus asymptomatic. And then too, so we collected our data over a month's time and split it up into two-week blocks. And you can see that during the first 2 weeks compared to the second, we had more patients with symptoms during this time, and it really reflects widespread community spread of the virus. And this was really before a lot of the restrictions for social distancing were actively in place. These were patients who probably got the virus sometime in March, we were still going about a lot of our normal activities at the time. And then if you look at the second block of time, we see a higher number of patients without symptoms compared to patients with symptoms. And what this might be reflective of is this type of test that we're using to diagnose our patients. It's a PCR test, and it's just identifying the presence of viral particles. It's not identifying active infection, nor is it identifying the maybe volume of viral particles that might be present. And so what we might be seeing here are patients who maybe they had a subclinical infection, but are now recovered, but we still are able to measure viral shedding. And this is a case series from our volume of patients from March 3rd to May 11th. We had, and so this includes all patients who tested positive during the time of their pregnancy. So before I was showing you data for patients just testing positive at the time of childbirth. Patients who maybe had already had a recovered infection were not included in that group. So these are all patients testing positive, where we had 8.9% of our delivery volume. A very small percentage of the 141 had severe or critical disease, 6 out of 141. And we did see the disparities in our patient population. We had a high number of women with Hispanic backgrounds affected by COVID-19 compared to non-Hispanic, Black, or white. And the two risk factors we identified for a worse clinical course were both the Hispanic ethnicity and obesity. And this is the most up-to-date report from the CDC, and it's gotten a lot of press because of the main findings. And this is that pregnant women were experiencing more severe illness. And this is some of the definitions of severe illness were, so more likely to be admitted to the ICU, more frequently receiving invasive ventilation, right? So this is your intubation, and more frequently receiving ECMO, right? So this is that extracorporeal corporeal membranous oxygenation, which is using the lines and external membrane for the oxygenation. It's not through intubation any longer. And I'm happy to answer more questions and why this might be during our moderated chat session. And then this is from the state of Connecticut. So I haven't seen an updated one come out more recently. This is from May 3rd, but you can see the disparities in care across Connecticut, both hospitalization and death rates, 2 to 3 times higher among our Black and Latino populations compared to white. In our pregnant population, we saw an increase in our Hispanic populations, but not the same in our Black populations. But this is reflected across the country as the virus has settled in and is disproportionately affecting our more vulnerable populations. And I just wanted to add as an example, so this is from the Society of Maternal Fetal Medicine, one of my professional organizations, and really trying to give strategies to help all of us provide equitable care during the pandemic for our patients. So in developing a universal testing program, what this allowed us to do is also create a COVID-19 obstetrical unit. Part of making this possible was the consolidation of 2 labor floors. So we have a single hospital system in New Haven that is at 2 physically separate hospitals, and each of our hospitals have a labor floor. So the one that I'm at Yale-New Haven Hospital is our bigger labor floor that is able to care for the full breadth of obstetrical patients from low risk to high risk. The one across town is a low risk labor floor. And so what we did is combined our units into a single location. And what this did was allowed us to conserve our resources. So not only our physical resources, but our staffing resources and our space resources during this time where we felt a lot of constraint and possible restriction on what types of healthcare we're going to be able to provide our obstetrical patients. And so, lots of things going into the creation of this unit. We can go to the next slide. Right, so in creating the unit, our patients are tested for COVID-19, and if they test positive, they're able to continue receiving their obstetrical care in a unit that has been specifically developed to care for them safely, to keep them safe, their baby safe, their support person safe, and the staff caring for them safe. And lots of things obviously went into developing this unit. But shared decision-making was one critical part of it, especially, and I think Dr. Higgins is going to talk a little bit more about the care of the newborn, but at the very beginning of the CDC and professional organizations were recommending that the newborn be separated from the parent at the time of birth, and obviously this is a huge, makes a huge impact on the birth experience for our patients. And as time went on, we really relied on shared decision-making with our patient to provide the safest and most desired care by our patients so that they were on board with the decisions around the care of their newborn. We did a lot of simulation, and these were unique because they were remote and or socially distanced as we got comfortable working in a unit that was in a new location, had a different operating room, and had different emergency protocols in place in order for us to keep our patients safe. We did develop a COVID-ready OR that was directly downstairs from this new unit. We had temporary expansion of our OB anesthesia services to cover this additional footprint in the office, or in the hospital. And we created PPE quick donning stations along with these quote-unquote doffacers to help us don and doff our PPE safely. And then also we worked with our pediatric colleagues in creating newborn care plans for our newborns. All right, and so just some of the logistics of consolidation of our obstetrical services during this pandemic. So necessity is the mother of invention, and we invented a lot of new things during this time, but some of the take-home clinical pearls were, start planning, and that planning probably should have started yesterday. We consolidated this unit in about 2 weeks' time, which in normal circumstances would have been probably a 2-year planning project. Early identification of key stakeholders to be involved in the consolidation of the services so that all of the parts could be fit in the right order, and simultaneously assess the ongoing obstetrical needs of our patient population, identify critical hospital resources that might be rate-limiting steps to the care we can provide, and then continue to project our needs during the surge and maybe second and third waves that we might see going forward. All right, so just in summary, obviously this pandemic we're all experiencing is very dynamic. It's changing all the time, and once you sort of settle into a routine, things go ahead and change, and the way that we keep safe and our day-to-day might change. There's a lot of asymptomatic spread, and there's a wide range of COVID outcomes. It leads to really unpredictable situations. And some of this I wrote this summer, and now I think we're starting to experience it here, where the change in season is going to bring people inside. And if we abide by the public health recommendations, really impinges on our ability to have social interactions with our friends and loved ones. And we need to think about how we're going to adapt to this environment that continues to change. And, we want to develop these sustainable ways to deter spread, and we have them, but we need to do it in a way that keeps our environments livable, functional, and joyful. And I think as healthcare providers, we want to acknowledge that when we place these recommendations for the public health recommendations that really are effective in limiting spread and mitigating the impact of the infections on individual infections, that there are a lot of concessions that individuals take and groups take on to successfully employ these strategies, and we need to be mindful and creative in thinking about ways to support our patients during this really stressful time. All right, thank you so much. I'll hand it over to Dr. Higgins.
Yeah, so we're going to move on to the baby. So once the baby's born, what's recommended is usual medical care, the neonatal life support if the child needs it. The providers, the medical personnel now wear a little bit of extra stuff. Generally, they wear a gown, gloves, a mask, and now eye protection has been added. So you may see, a provider with a face shield in the delivery room. Delayed cord clamping is a usual practice, and this is still promoted during the era of COVID, unless the baby needs something right away. And then skin-to-skin contact, meaning the baby is held on the mother's chest right after delivery, is still permitted. And if the mother is COVID positive, she's supposed to wear a mask when the skin-to-skin contact is done. So basic delivery room care, unless there's an emergency. So if we go to the next slide, there is new emerging information. There has been set up a national registry for perinatal COVID-19 infection. This was set up through the section of neonatal perinatal medicine. Dr. Mark Hudak, who is the section chief, has started this. And currently they have, what they're collecting is positive maternal cases. They had, as of a couple of weeks ago when I got the update, they had about 3,000 cases reported. This is voluntary reporting, and any institution that's doing it needs an IRB approval, and then they can report to the registry. 2% of the newborns tested positive, and this was positive tests between 24 to 96 hours of life, so before the infants went home from the hospital. And they are trying to follow them out up until 30 days to see if they turn positive after they end up going home or if they have an exposure. So basically what they're concluding so far, and again, this is emerging information, that this is low risk. And unless a mother is acutely ill, rooming in is permitted according to usual practice. And if the mother, again, if she's COVID positive, she's supposed to wear a mask. If we go to the next slide. Lots of questions about breastfeeding. Breastfeeding is the best choice for infant feeding. And to date, no viable virus has been detected in the breast milk, but this is ongoing and an evolving area, so people are continuing to study this. If a mother is positive, she's encouraged to use good hand washing and to wear a mask, and she can actually nurse her own child. If she's not feeling well, then express breast milk from the mom may be used and fed by another care provider. If we go to the next slide, so if you have a baby born to a mom that's positive, the current recommendations as per the American Academy of Pediatrics, which were put out late September, early October, are to bathe the baby following birth after the skin-to-skin contact to remove potential virus on the skin. The baby should be tested at 24 and 48 hours, albeit though, remember, I just told you the testing positive is very low. If the baby's healthy, they can go home at 48 hours with the mom. If the baby's positive, they're being closely observed. They can go home if they're asymptomatic, provided they have good pediatric follow-up. And then at home, again, if the mother's positive, the mask is needed, and then hand hygiene until the mom has had no fever for 24 hours or 10 days after she's turned positive, or if her symptoms improve. So this is a change from what was originally recommended to separate the mom and baby, because you lose that bonding, and breastfeeding really needs to be initiated early. And I think with the emerging data that the rates of infection in the infants were very low, there was more permissiveness allowed for the babies. Now, if a baby does develop signs and symptoms, these are the things that can happen. temperature instability. Babies are more likely to drop their temperature and not be able to maintain body heat than older children to develop a fever. Some, however, could develop fevers. If they're not feeding well, nasal congestion or stuffiness, flaring of their nostrils, or irregular breathing. If they develop a bluish color, if they become lethargic and not responsive, and they can also develop diarrhea. So these would be things that would trigger a potential, a COVID infection in babies. These are some of the signs and symptoms. If we go to the next slide, follow-up of the baby that goes home if the mother's positive. It's routine pediatric care, and that can either be done in person or via telemedicine. And many of the pediatric practices are going to telemedicine. Most pediatric practices have separate waiting rooms now for infectious versus non-infectious children. And then the most important thing is immunization should be given on schedule, and so those need to be done in person. In many pediatric practices, what they're doing is a telemedicine visit and then sort of a drive-through immunization if they have the resources and facilities to do that. But we definitely need the immunizations on schedule, because what you don't want to do is try to avoid the one infection from COVID and then have something like a polio resurgence or children with whooping cough, pertussis, those sorts of things. If we go to the next slide, this information, again, it continues to evolve. And as I said, the initial American Academy of Pediatrics guidance was to separate moms if the moms were suspected or confirmed with COVID from their infants. It was a very cautious recommendation, and I think the recommendation was put out there because people were concerned that this virus could cause potentially a life-threatening illness in the babies. Now the pendulum has moved back and rooming in is allowed, and this is really a ripe area for research to inform practice going forward. And the guidance may change over time as more information becomes available. If we go to the next slide, this is a little graphic that was published recently in the American Journal of Perinatology to try to give people a pictorial representation. So when the baby's born, that's the upper left-hand corner in the blue, the healthcare workers wear full personal protective equipment, which is slightly different than what you have with a normal delivery. The baby gets a bath after birth. There are, nose and throat swabs to culture to get a PCR test, if that's polymerase chain reaction test, to see if you can detect the DNA in the baby. And then temporary separation and express breast milk feeds can be done if the mother is sick. When the mom's, less contagious, she should just wear the mask and practice good hand hygiene, and breastfeeding can be considered. And you can see this is evolving because this was published, I believe, online in late July. And delay timing of the discharge if the baby's symptomatic. However, if the baby's fine, they can be discharged on time. And then watch closely for signs of COVID. And then close follow by the pediatrician and, again, routine immunizations. If we go to the next slide.
Rose, I believe that might be your last slide.
Okay, so that's fine. And again, this is evolving information that may change over time as more evidence becomes available and publications are out there. So thank you.
Thank you very much. We do have a number of questions coming in, and I encourage everybody to submit their questions via chat. The most frequent question has been about the slides, and we will certainly make those slides available via email along with the recording of the event. We do have a question about how quickly the tests were coming back. I believe this is for Dr. Campbell. How quickly were you receiving test results back in the beginning of the pandemic?
Yeah, that's a great question, because definitely a critical component to running this type of program. In our hospital, we had two separate testing platforms. We had a rapid platform and a standard platform. So the rapid platform, the test would come back on average in about 2 hours. And with the slower turnaround time test, that test would come back somewhere between 6 to 8 hours. And so we worked with laboratory and infection prevention to triage our childbirth patients to the rapid testing platform so that we would get the information back in a timely manner and our patient coming in for childbirth could be triaged appropriately.
Is Yale following any of the COVID positive mothers, and if so, what kind of outcomes are you tracking?
So there's, I think, two parts to that question. We follow all of our patients who become COVID positive with routine telemedicine visits, and they're checked up on at least twice a week by our providers to ensure that they're continuing to stay well at home and don't need a higher level of surveillance, perhaps in the hospital, because we know that some of the most severe symptoms of COVID can peak around symptom day 8 or 9. So that is part of our practice and something we implemented early on. And then in terms of long-term, so one of the slides I showed you earlier was looking at our cohort of 141 patients, and so those were longer-term outcomes. But I guess the bigger question is even looking at longer-term outcomes of 6 to 12 months and seeing what type of impact. So that would be another good area of study.
Rose, I think this question is for you. Are there any benefits to freezing breast milk for antibodies? We have someone that currently has COVID and is considering freezing breast milk.
So there's no data out there yet on that. People may end up doing that, but we don't have information that says the antibodies are there. So, for instance, you're saying a mother who may be in the convalescent stage of COVID, if she's got the antibody in her breast milk, could that potentially help her baby or even other babies if she was donating it to a milk bank? And we just don't have data to say yes or no.
And follow-on question to that, do we know for sure that the virus is not transferred in breast milk?
So to my knowledge, as of today, there's no documented transmission of COVID infection through breastfeeding. However, I think, as evidence accumulates, that's something that we need to watch for.
Is there any evidence of developmental issues if the mother tests positive while pregnant and if the baby is born COVID negative? And does this vary by the severity of the infection?
So again, not enough data. And that's one of the things, the registry that's been set up is for short-term outcomes. I think, as time goes on, you would want to follow the children, into toddlerhood and school age to see if there are long-lasting effects. But, because we're so early in this pandemic, the data just aren't there.
Did the COVID infection rate in pregnant mothers have any impact on the preterm birth rate?
So in our patient population, the N is small. We did not see a strong correlation, but the bigger studies, observational studies that are coming out is seeing an association for our COVID positive patients and preterm birth. And the reason for the preterm birth is probably multifactorial.
Right. I'd emphasize there's a lot of case reports on this, and the series are coming out. Many of the case reports are also confounded by the fact that there's other complications, or the mother may have been from one of the high-risk groups like Hispanic or African American or obese, those sorts of things. So I think, we need to see more data coming down.
Yeah, I agree. And, I think we're all worried about the impact of COVID on pregnancy outcomes. Lots of decisions go into, managing a pregnant patient with COVID. And you want to differentiate this spontaneous preterm labor with iatrogenic preterm labor, meaning that there was a medical decision that the pregnancy needed to end and the baby be delivered prematurely.
we have a participant who has observed an increase in the number of fetal demise cases and wanted to know your observations on whether you've seen an increase in these cases since the spring.
So there was a study that was published from Great Britain. I think it was maybe late spring, early summer, where they noted an associated increase in their stillbirth population. We actually did a quick survey of our own here, and we did not see that association between stillbirth and the timing of the pandemic. Obviously, I think more research is going to need to be done in this area to see what, if any, associations between the two.
In your opinion, did social distancing measures and limiting visitors have an impact on postpartum depression?
So it's actually the visitor limitation. So during the peak of our pandemic in the spring, our patients in the hospital always were able to have at least one support person with them during their childbirth and hospitalization. There were actually some benefits of this visitor limitation, in that we actually found a lot of patients had actually a very enjoyable experience because they had extra time to bond with their baby. We saw some increased rates of breastfeeding, more time for the patients to rest and sleep, and anecdotally, a lot of positive feedback from patients who enjoyed that time here in the hospital without a parade of visitors coming in and out of their hospital rooms. But it is a huge concern for our patients going home when we're asking them to socially distance. Our patients come from a wide array of backgrounds, and sometimes they go home to places that might not be physically safe for them. We're very concerned about intimate partner violence, especially when we're recommending all of this social distancing and the restrictions around that. And it's a stressful time for our patients. We see that when they come in postpartum. And so we've been trying to do more work in this area to make sure that our patients are being supported. But I think it is it's a big ongoing risk for our population.
Can you explain more about the relationship between obesity and COVID impact?
Yeah, so we're definitely seeing an association between disease severity and obesity. I don't think we know exactly the role of obesity, and it might be that it's a confounder. There might be other medical comorbidities that are associated with obesity, for example, diabetes and hypertension, that could be the primary driving factor. But there also are other conditions like sleep apnea and that might be exacerbating a case of COVID in a patient's respiratory symptoms. So I think stay tuned, there's more to come. I think we need to get a better idea of this association and what's really driving it.
One other item on the obesity is there's theories out there that obesity represents some sort of subacute chronic inflammation, and so that may also be contributory. And then the other thing is with a woman who is pregnant who's obese, it's well known in pregnancy that the further along you get, the more your diaphragm muscles are pushed up just by the enlarging uterus or womb that you have, and so there may be a little bit more stress on the lungs at that point in time for breathing. And I don't know if anyone is looking at sort of gestational age and the mother's weight and the need for mechanical ventilation and/or ECMO.
What is the recommendation for untested OBED or triage departments?
Does that mean like how do we keep our patients safe if we don't have a universal testing program in place?
That is the question that has come in through the chat. I'm not sure. Maybe we can have that person clarify while we move on to the next question.
I mean, I can talk a little bit just about that rephrased question. So, PPE is a critical part of, keeping our unit safe. And so having our patients wear masks at all times that they are able, having their labor support person wear a mask for the duration of their stay, and then having our healthcare workers in the appropriate PPE, whether that's a mask or respirator, face shield, and then the gloves and gown. And so that really is your primary prevention. So even if a patient has an asymptomatic infection, if you're wearing the appropriate PPE, that's considered a lower risk interaction. And when they're symptomatic, having the right PPE on will also result in a lower risk interaction. So PPE is the answer.
Is there any reason to think the experience for pregnant women with COVID might be different in this next wave based on mutations of the virus or other factors?
Well, if you guys could have seen the presentation I sent over on Friday, what I had was a 14-day rolling COVID rate that actually was not reflective of the state's surge that we're seeing. Our surge on our labor floor was a little bit delayed, and I was really hopeful that our pregnant patients were practicing more closely to the public health recommendations and maybe doing more social distancing, limiting their social interactions, avoiding a lot of indoor public places. Anecdotally, here in our hospital, our internal medicine physicians are saying that the COVID cases, they're recovering faster, they're less likely to need care in the ICU, and they're responding well to our two main treatment therapies, which is the dexamethasone and the remdesivir. And so we hope to expect the same for our patients now that we have a better idea of these clinical courses. But in terms of the virus mutating and having a less severe impact, I think that has been hypothesized, but I don't think we really know if that's happening.
How symptomatic or how contagious is an asymptomatic mother considered?
That's a good question, and I think it depends, right? So right now we don't know if an asymptomatic mother is in her pre-symptomatic phase, which we know is a time where there is a lot of active viral shedding and patients are very contagious, or if this is the resolution and sort of a remote convalescent part of recovery where they've gone through their infectious phase and now they just have low level of viral shedding that's being picked up on our PCR test. And so we don't know, so we have to take uniform precautions.
This goes back to what you were saying about PPE. Given that there were so many shortages of PPE last spring, do you anticipate this will become an issue again during this next wave?
I mean, I really hope not. Now I feel like our industry has had a lot of lead time in producing adequate PPE supply. I do know that currently our hospital does have PPE. We're going to continue to use all the conservation measures that we have in place, like the recycling of masks, using the UV sterilization, not wearing makeup underneath your masks, and just being very cognizant of how often you turn over your mask. But yeah, I'm hoping that it won't be as big of an impact.
Let's see. Do you think that the current birthing model will need to be adjusted if and when another spike occurs, and if there's an influx of pregnant patients admitted to the ICU?
I think right now what we're doing is the model that we had this spring when we had a high volume of community spread of COVID with a single labor support person and all of the protective measures in our hospital. I do hope that, similar to this spring, that we continue to only see a minority of our pregnant patients requiring higher level of care, either in the step down or the ICU. And these public health measures, I think one of the important take-homes is that wearing a mask, social distancing, hand washing, they all contribute to lower volume of virus coming in contact and being breathed in, which can result in a less severe infection. And so I'm hoping that we will see, the majority of our infections will be less severe.
One attendee is citing some statistics from the Wall Street Journal saying that pregnant women are shedding the virus up to 100 days versus 8 to 31 days. And what does that mean for the time the patient is contagious?
Right, so we understand the contagious period. There's a pre-symptomatic phase and then the symptomatic phase, and that active virus really is not obtained after about 8 days from the onset of symptoms. And so even if you're picking up viral particles, let's say 30 and 50 days out from an infection, they're usually present in such low quantities that it cannot cause infection in someone else, so they're not infectious. So right now, we're using that same 90-day retest window that's advertised and supported by the CDC.
Are you looking into how long immunity may last for positive women? 90 days is being talked about. Is that the same for pregnant or delivering women?
Yeah, so if a patient is recovered from her COVID infection and it's been less than 90 days when she comes in for childbirth, we don't retest them. We treat them as recovered. But if more than 90 days has passed, then we will retest them. We don't know, right? I don't think we have an answer if and when patients can be reinfected with COVID-19.
So if I can add, there was an article in JAMA last week or the week before that followed healthcare workers, not necessarily pregnant. I'd have to go back to the article to see if there were any pregnant women in it. But they were looking at immunity with the presence of the immunoglobulin, and that waned over time, which would point to the fact that, if they don't have as much antibody left, then a potential herd immunity may not be the way out of this thing.
Mm.
That concludes all of the questions from the chat. Is there any closing thoughts that Rose or Katherine that you'd like to share with Jermaine?
Well, I certainly want to thank Katherine for being on the front line and all of the help and that the entire medical staff is doing in support of trying to keep COVID under wraps, if you will. And certainly these are ripe research questions, so it will be good to finally get to a point where we have sufficient data to help guide clinical practice and certainly inform public health guidance moving forward too. So thank you both so much.
Thanks, Dr. Lewis.
Thank you.
Yeah, I guess my parting comment is really sort of a rally cry. I think this is going to be a tough winter, and but I want to encourage all of us that we have a lot of new knowledge about the coronavirus, and we have a lot of public health recommendations that really do mitigate the spread and the seriousness of COVID infections. And so I think we're just going to have to take it day by day and work together. And I think we'll get through this.
Thank you very much. Thank you for everybody attending. I wanted to just draw your attention to 2 additional events that we have coming up. We have our next webinar in the COVID-19 webinar series, December 11th, on COVID stress syndrome. And then the HAP TIPRI Health Policy Seminar tomorrow from 12 to 1. And information on all those events can be found on our website. Thank you, everybody, for attending. Thanks for a wonderful webinar.